David and I want you to know that we expect it and respect the fact that there are other ways to do these procedures for sure. Many, many different modalities. What we're trying to share with you is just simply our perspective, how we look at cases, and how we deal with these types of deficiencies and defect environments. But many times people have asked us, what do we do in situations where there isn't a defect, where you have a type 1 site? How do you manage that site? And I think we shared with you this morning managing these interfaces through prosthetics, artificial gingiva, and then surgically through bone and soft tissue augmentation and tissue molding of the provisional. And now I think we need to take you through preservation and maintenance strategies, because many times we have patients that have ideal anatomy, what we call type 1 sites, and what we want to do is to maintain those type 1 sites for aesthetics as well as longevity. And this is a critical aspect. What we're going to show you today is some of the current literature, what you should know about those indications, because there are probably more of those implants being placed today than ever before. David?
So we're still in this particular realm, surgical reconstruction. And we're taking you just to looking at a single tooth because it gives you a perspective on all we can do on one tooth. And then remember, multiple case, which we're going to show you in a short while, is just a series of single teeth put together homogeneously. So this is a type 1 site. As we said, type 1 site means the periodontium, the soft tissue and the hard tissue hasn't been compromised. I actually did this crown some years ago without really paying sufficient attention, didn't have a long enough ferrule on this. It lasted 3 years and of course it broke again. And I've now got to get it out. And the nice thing of course is, look at the soft tissue. It really is, for the most part, ideal. The bone hasn't been compromised as yet, so it's a nice way to go in. The soft tissue form is exactly as I wanted already right from the outset. So our first decision then is, I said with Maurice, immediate or staged. You know, there are two schools of thought. If we stage it, we put a graft in, we wait anywhere from 8 to 3 months, 8 weeks to 3 months, and then go in. But by that stage, remember, 3 millimeters of this tissue, the bone is up there. That's the most crucial part of your transition zone changes. So if I can keep it rather exactly like this, and not have to redevelop it as you saw, we're much better off. This is an article that Dr. Salama published with a group that we work with, a team in Japan, and it talks about the timing, the critical timing, as well as how you sequence implant therapy. Remember, we were just talking about staged, the various forms of staged or immediate. When to do what, how best to decide that. So realize, look at this process. You're taking out a tooth. Here it is coming out atraumatically. Think about what's behind it. You've got a thin piece of bone. How thin is that bone? For the most part, it's around about 1 millimeter. How much? About 90% of them are 1 millimeter thick. Maurice told you we need at least 2 millimeters if we're having implants. That means 90% of our cases plus immediately have to have bone. That's the first thought process. Look at this thin bone. Get an idea also where you're going to place your implant. Understand we're going to have to add bone. And maybe we'll have to add soft tissue, because it seems the soft tissue allows the bone to remain there on a more continued basis. So when you're looking at the data, remember we can do a staged approach, Danny Boozer style, extract, graft, and they wait somewhere between 12 and 20 weeks. This is the dual zone that Maurice talked about, and that's immediate implant placement, and SVG, that means surgical veneer grafting of the site simultaneously and putting in the provisional. So that's your second option. The third is kind of early delayed, which means an earlier version of this in most points. And then this is the one that we really want to show you has, we believe, enormous potential. It changes the way we think about things entirely. It changes our surgical procedures quite differently. So let's take you through a standard one of these. In this particular case, I talk with Maurice, we decide immediate's much better. It's thin tissue, it's thin bone, but we will be able, we think, to keep it all and then add to it. Sorry. So again, this is intact. It's a thin gingival biotype. We're going to do immediate. We always put connective tissue at the time or later. Our chances of a good result are really pretty good. So your first thing is raise your flap. Plan where you're going to put your implant. Remember, it's not where the root was. Teeth are not implants. So you really have this little triangle of bone. You're going down that way.
If you take a look at this image, this is exactly what you don't want to do. This is a selection of a wider diameter implant. You can see it engaging this thin labial bone, not staying towards the palate with a screw access that will come out through the labial. This type of plan is fraught with problems, and this is probably the #1 reason for some of the aesthetic failures that I see in the anterior region. So that's why I said earlier that we predominantly utilize standard diameter or slightly smaller diameter implants in this area. We always place it, as David's showing here on the CAT scan, towards the palate, and we always try to keep at least 1 to 2 millimeters of distance between the implant body and the labial plate.
So you can see how thin the bone is. We've raised the flap over the papillae because we probed that bone sounded, and we know those papillae are predictable. We're accessing, remember, the palatal and interproximal bone. That's the key. Don't touch the buccal bone. Don't even look at it. We're going to approach this with the dual zone concept, surgical veneer grafting using both modalities. This was again published with Stephen Chu and Maurice, and again, you can find it in compendium or go up onto www.dentalxp.com and just download it for yourself. Really an important article, and we're talking about reducing ridge alteration following extraction, which we know always happens, not sometimes, always, even if you put an implant, and the way we're doing that is with surgical grafting.
Now, this was an article that was published. If you want to look at any of these, as David mentioned, you can find these PDFs on Dental XP, or you can go to the Journal of Cosmetic Dentistry. We published on this, we submitted it in 2015, but it was published earlier last year in the Journal of Cosmetic Dentistry. And it was a group of Italian dentist brothers, Andrea and Alessandro Agnini, as well as our team in Atlanta. And we did 30 cases where we compensated for natural resorption of immediate placement cases, immediate implants, using bone in the gap and then soft tissue in a tunneling approach, supraperiosteally outside between the labial plate and the tissue. And we followed these cases, and now we're going to be publishing a 5-year post-op on these next year. What we found is tremendous amount of what we would say tissue maintenance. The tissue, as David mentioned, doing 2 things. Number 1, thickening the keratinized gingiva and maintaining color and tissue position, but also there seems to be a relationship that has been clearly shown by a researcher in Europe in 2010, Tomas Linkevicius, who showed that when tissue is thick, 2 millimeters or greater, it maintains crestal bone. So what we're seeing is this tissue that we're adding in this tunnel at the time of immediates may not only be compensating for remodeling, it may in fact be preserving bone as well.
So again, look at where you're placing. Remember, we're trying to stay away downsize your implant from the buccal, because you can see that remaining bone is toast. And we'll show you what happens to that bone. Don't think if you've got it long term. You need a minimum of 2. And Maurice has just told you 2 things. There's several 2 millimeter rules, aren't there? 2 millimeters of bone, and 2 millimeters of soft tissue to keep the bone there, and 2 millimeters to prevent color bleed through.
If you take a look at this, this is a case I did. I can tell you that I'm unhappy with what I'm seeing. One of the great things about photography, you learn from your own photographs. We take a lot of pictures. I placed this implant and I placed it too close to the labial. It's not touching, but I would rather be more palatal. I would rather be more like a millimeter, 1.5 millimeters, 2 millimeters. I'm probably less than 1 millimeter away, and that bone is very thin, and that's not a position that I believe is conducive to long-term success. So this is, to me, that's why I say freehand placement. You really have to really lean your burr and engage that palatal wall, because even an experienced surgeon placing a lot of implants, all it takes is a couple of seconds while you're drilling for your wrist to turn and that implant to go bodily or tip labially.
So you can see the bone is incredibly thin. We talked about grafting. What kind of grafting are we going to do? And realize there are several areas that you're going to graft. You're going to graft on the outside, beyond the ridge, and you're going to graft into that remaining gap. And you use different bones, don't you, typically, when you do that. So it's slower resorbing on the outside. On the outside, slow resorbing materials, and on the inside of the socket, something that's a little bit faster in terms of resorption. So cancellous bone chips internally, inside the socket walls, and then outside the socket walls, cortical chips or xenograftic products. And you can see he's really overcompensated with the bone. He's got the fibrin on top of that, and we're going to put soft tissue on that based on the literature which has shown it. So we're preserving what's there, and then we boost it. We boost it aggressively, knowing that we anticipate losing some of that. So here is soft tissue. It wasn't quite a tunnel. It was a little more than a tunnel, as you saw in this particular case, because of the need to graft so far apically. And the tissue is over the grafted bone. And this maintains the soft tissue based, again, on Linkevicius's work and, of course, Uli Grunder, Chan, and the others. Look at the amount of overcompensation. And this was an interesting article by Otto Zurer and Hannes Wachtel and the group. And they showed that overbuilding the buccal aspect, as we're showing you, in socket preservation with implants, doesn't compensate entirely for the resultant effect of taking out a tooth. Taking out a tooth, remember, as we're finishing up towards the end of the day, is really one of the most aggressive iatrogenic things we do. This is 9 days, and really, tissue's looking pretty good. I copied exactly as you saw the temporary, the same way. At 2 weeks, you can see, looks like we're losing a bit of tissue over there. Anybody worried about it? Shouldn't be worried. Why? Because you knew where the bone was. You know you'll get tissue 4.5 millimeters from that proximal bone. The interproximal bone is your stable point. So that's no issue. I'm not worried about that. There is where we were. And now at 14 months, you can see how that's all tightened up. We've got really quite a nice result on the match. The tissue looks really outstanding. You can see that huge abundance of tissue has really gone down somewhat, but we anticipated, and holding really nicely at 14 months. So we were quite pleased with ourselves. 6 years and we're still pleased with ourselves again. Remember, the proximal papilla never is a problem because it's dependent on the adjacent tooth. It's not this measurement, it's this measurement to the tip of the papilla. Remember that. The key problem we always have is, of course, on the buccal, And that's where we see the labial change. Remember, 2+ millimeters of bone, and Dr. Salama did that exquisitely. This is around about 3+ years, and you see a slight change in the incisal edge. All your patients must be in some sort of retainer for implants. You will see open contacts. You will see extrusion of this tooth over a period of time. It is perfectly normal. So warn them in advance. This is informed consent. And now we're looking a little later, 4+ years, and you're beginning to see like a progressive slight change in the volume of this tissue down the road. You remember how fat it was up here? You're kind of getting a little indentation over there. No real change in color. It just doesn't look quite the same, does it? Took the X-ray in 2016, so now you're up close to 10 years on it, and it looks fabulous. I mean, look at this bone, look at this bone. This is 102% when you look at it. I look at this, and it doesn't look the same. Remember, this is where we were. We built out beyond that to the top of this pink, and we're all the way back over the years. Quite amazing, isn't it? And if you take the CAT scan, just a little later, you can see how much bone has been lost. And you all saw the bone, didn't you? And you saw bone that doesn't tend to die back. This is actually a 3-shape unit. We scanned the tooth beforehand, we scanned the tooth afterwards. At 2017, you can see the adjacent teeth stayed exactly the same. You see the purple and green are identical positions over all the years. Look what's happened on the tooth that we did the implant on. Quite a big difference, isn't it?
I just want everybody to know in this room, how many of you are doing or involved in implant procedures? Okay. You all have many of these walking around. You're part of this club. You may not know it, but you're part of this club. That cone beam CT unit, how many of you have one or use one? Okay. The worst thing about CBCTs is where you end up having it taken on a patient you treated 10 years ago. Because then while you're looking at the new tooth that needs an implant, you glance over at the one you did 10 years ago, and it may in fact just look like what David's showing you in the middle screen. Just saying. You know, and then all of a sudden your assistant who's been with you 25 years ago, did you take a look at that implant on the other side you did? I said, no. I didn't. And you shouldn't either if you want to continue working for me.
It's a big club. It really is a big club.
Let's all be honest. Like my wife tells me to go up and see my kid's room. And I said, why would I do that? She says, it's a mess. So I said, if I know it's a mess, why would I go up there?
And this is the scan, again, showing you the volumetric loss differently.
So let's take a look at this. This was a real big issue, and this continues to be a focal point of worldwide discussion. Not just here in Vegas, and it's amazing what a great audience and all the outstanding people that are here, because I've just seen so many of colleagues and friends that I knew. So again, compliments to Keystone and getting this and inviting us. We certainly appreciate it. But this is a worldwide issue we all are facing, whether you want to recognize it or not. The only way to avoid it is if you want to move offices or move states every few years, you'll never see it. One or the other. One of the worst things about being in Atlanta is I've been in the same darn office with the same assistant, same hygienist for about 26 years. So that digital stuff and servers where the patient goes, you know, it didn't look like this when Dr. Garber and Dr. Salama did my case 12 years ago, and the assistant will, the hygienist will pull up, oh, let's take a look. Yeah, you know what, Susie, you're right. Didn't look like that. And then you'll come into the hygiene room to see the patient, and it's an ambush. They have all the information against you before you walk in the room. You can't even claim fake news. So I'm sitting there with Stephen Chu. For those who don't know Dennis Tarnow and Stephen Chu, you just simply haven't been out enough. Stephen and Dennis are some of the world experts, leading authorities, and part of the fellowship in Dental XP. Been faculty members at NYU and Columbia for many years. And I'm sitting with Stephen, it was 2006, 2007, and he says, Maurice, I gotta show you some cases, and I want your opinion. And he pulls this case up. Did this case with Dennis, and Stephen is a certified dental technician and a prosthodontist. He's phenomenal. Dennis is obviously perio and pros trained. This was done by some of the best dentists in the world. And he said, you know, I've seen this after 12 months, 2 years, 3 years, starting to lose volume. I'm starting to get color changes. I'm losing volume in these immediate cases. Look at the natural tooth and look at the implant-supported crown, look at the discoloration, the thinning of the keratinized gingiva, and you know if you took a CT scan of this, you know what it would look like. And this is more of a problem if you're going to be sticking around, because it's much easier to deal with these cases before the final restoration. So I'm just going to point that out, because you're going to see a case shortly that David and I are going to show you where we intervened before this happens. Because patients come in and they say, start smiling, and you see the color of the bleed through. That's why the anodized portion and the anodized abutments that you see with the Genesis may in fact give us some help, at least not show the bleed through as easily in this area. But we need to know, what do we know today, 2018? What do we really know? Are we going to take a peek at that cone beam CT? Are you going to go up into the room and see what your kids are doing upstairs like I should? We need to know that implants, if I had to leave you with one iota of important information, it's just simply this. Implants are not teeth. They don't work like teeth. They don't function like teeth. They don't have a periodontal ligament, no proprioception, but even more importantly for us and what we do each day, they require more bone and more tissue for longevity than teeth do. Plain and simple. Teeth can get away with a ½ millimeter of bone or less, and even as little as less than a millimeter of tissue, and you, in a healthy environment, can preserve it. Ideally, the literature, over and over, studies by Young, Linkevicius, Joseph Kahn, many others, have suggested 2 millimeters of bone in front of the implant body and 2 millimeters of soft tissue, ideally. That doesn't mean we're always going to get there, but that would be something that we envision. So that's at least double the amount that you have around the natural tooth. This is another case Stephen showed me. Crown came off, the cement leaked, and the patient came in to get it re-cemented. This is at 18 months. Look at the depression in the ridge. It's a natural tooth, and look at the concavity here. This is a custom abutment with opacious porcelain to try to hide the discoloration, but you can't hide that discoloration, can you? The bone remodels, and as the bone remodels after loading, and this doesn't only happen after 1 year. Ladies and gentlemen, I'm telling you, the case David just showed you, the case looked great at 5 years, looked great at 6 years. All of a sudden, you start seeing some latent remodeling, 8 years, 10 years, 12 years. That's why I suggest strongly, move from state to state. It's much better. Just pick a couple places you like. Find some friends. I'm sure there's a bunch of people in the room here. I met them. They're all over the country. You know, tonight in Vegas, you know, rub some elbows. Facial contour, facial contour. Look at the tissue quality. There's a study that we're trying to get completed with university where we're talking about over time, as the bone thins, that it not only affects the bone on the CAT scan, it affects the quality and thickness of the keratinized gingiva. That's something no one has reported. The tissue thins when the bone resorbs. The tissue, why? But the tissue does thin. And if you look underneath there, this is what you're going to find. That's what David was showing you on the cone beam CT. That's what it looks like. And ladies and gentlemen, there are millions of these implants out in the real world. We may not want to admit it. We may not want to look at our CAT scans. But the fact is, thank God, if you have thick tissue and you place that implant palatally and you overcompensate it, this isn't going to fail most of the time. But you may have tissue changes, color changes, recession, abutment exposures. You want to compensate for that. What do we know in the literature? Many studies in the last decade. 2005, Orojo said, hey, listen, that's that old wives' tale. Remember we used to hear, how many of you remember hearing, if you place an implant at the time of extraction, it preserves the labial plate? Anybody remember hearing that? Yeah. If you're old enough? If you're not, I'll tell you, I used to hear it. Completely grandma's story. It's not true. He showed it on beagle dogs. It does not prevent remodeling. This is from Ron Nevins on humans, 2006. He took out teeth, he took a baseline cone beam CT, and he stuffed slow resorbing bio-os, xenograft material, into the socket. And 180 days, he came back, took another cone beam CT, and what did he find? He was able to preserve 80% of the socket. That sounds pretty good, right? But look at what he lost. It was the 20% that's the most important. It's in the interface that we talked about earlier. The bundle bone, Lindy talked about, that this bone is relying on the tooth and the periodontal ligament for its blood supply. So no matter what we do, it's stuffing these sockets. You know, I heard people always talk about socket preservation. There is no such thing. If you stuff a bone in a socket, you're not preserving it. It's a socket graft, and you're going to end up preserving 80%. You may lose 10 to 20%, that little bit here. And that's why that anodized surface with that implant may in fact help us in that area. So as it resorbs, you have a pink interface. Look at this study, and recently, and I really want to, for a moment, just say that Dr. Carteropoli recently and suddenly passed away, and he was a great researcher, a very kind gentleman, and I'm sorry that happened only this week.
And young.
But this study was one of his, really one of the ones that I always used to thank him for. He published this in 2006 while he was working in Sweden with Jan Wenström, Ulf Leckom, who are really world-renowned researchers, and they looked at single tooth replacement at 1 year, a prospective, not a retrospective study. And they said diminished bone dimensions, horizontally and vertically, affected the soft tissue and the aesthetic appeal of the final restoration. 2006, we're reporting it to you today in a real world. They did this study in a clinic, in a prospective research center, implant center, and that's the truth. And we see a lot of these types of problems. So do we really know the long-term impact of this remodeling? We know that what happens because we see it. We're seeing it on cone beam CTs. You're seeing color changes. You're seeing abutment exposure. We all see it. There's nobody in this room who hasn't seen it, or you're not looking. But do we know when it happens and how long out? Some people used to say, hey, if it's still there after 12 months, then you're fine. That's not true. It's not true. David mentioned to you about thin labial plates. Yes, it's been shown in the literature, 2010, less than 1 millimeter for sure in the anterior region. Look at these extraction sites. Look how thin the labial plate is. There's no denying the fact that this is cortical bone, poorly vascularized, and if you're going to raise the flap especially and you strip the periosteum, that bone's going to be gone. So you need to do something to overcompensate for that remodeling. This was a cone beam CT study done in 2011 by Belser and Boozer, Brout, and their team. They said 63 to 80% of the labial plates measured on CBC were less than 1 millimeter. That's a cone beam CT study. This study said the thickness of the buccal bone and the dimension of the gap influenced the hard tissue alterations that followed immediate implant placement. So if you have thick bone, the labial, it's a small percentage of the population. You're lucky. I was doing a 25-year symposium at Loma Linda with John Coyce. And John put up a slide about what kinds of cases were ideal to be treated. And he said, 1.5 millimeters keratinized tissue, 1.5 millimeters of bone, 4.5 millimeters from the contact. And I said, John, where do you work? Because I don't have any of those patients in Atlanta. Maybe I have to fly to Seattle. Because you're not going to always get those patients walking in your rooms. You're going to get them like the averages, which are typically less than 1 millimeter, thin plates, thin tissue. If you're here, we're in Las Vegas, you're going to go to a slot machine when you know that 80% of the time you're going to lose, you're going to have to walk to another machine. So maybe next time when John comes to Las Vegas, I'm going to go to
play with him.
Look at these problems, and they're here. We know they're here. We have to deal with them. So take a look. This is clinical information that we do, new scientific evidence. If we take out teeth today, I took out this tooth a year earlier under a bridge, and I come back, and a year later the bridge breaks. He didn't want to remove the bridge. We had a cantilever, and eventually you know what happened. Biomechanics, the bridge fractured, the teeth fractured. Look at what happened in this area in 1 year, and I grafted it with bone. It collapsed. Even if I had an implant in there, you would have had the same issues. And if you follow the bouncing ball, the reason the tissue collapsed is because the bone collapsed. And if you take a look after these teeth were extracted very atraumatically, which I always get a big kick out of, atraumatic extraction, I think we all try to take out teeth atraumatically, the bone is very thin on the labial. So I can go ahead and place my implants. You can do a guided today. You can do it with a 3D scanner. Outside the socket, I want a slow resorbing material, something that will stick around a while. Inside the socket, I want something that has a higher turnover, and I'm going to mix with a growth factor here. I'm using sticky bone. You can have it with PRF or PRGF, whatever you'd like. Both of them, to me, work very, very well.
And you can see the trend to smaller implants, avoiding even getting near that buccal aspect and staying very far lingual. Much smaller. I mean, we used to use 6.5mm implants. It's a whole change in philosophy.
So now you can see we're grafting outside of that labial plate. We add a slow resorbing bone and then multiple layers of fibrin to seal it. We want to contain that. You can use collagen membranes. And then over the top of that, I'm going to use a thick piece of dermis or pericardium to increase tissue thickness. I'm going to add a little bit more of the growth factors, and I'm going to coronally advance the flap. And hopefully, I'm going to attain this type of early closed healing environment. I coronally advance it, and I try to get thickness of tissue and height of tissue that I can then pass along to David for the restorative phase. So this is what the implants look like. Look how thin. Look at this. There's a green stick fracture. Look how thin the bone was distally, just 1 millimeter away, less than probably 0.5 millimeter at best. This is 5 months later. Bleeding bone, well integrated with the host bone. You don't see that green stick fracture here, and this is healing abutments, not cover screws. We actually have bone above the platform of the implants. So if we're able to use GBR, if we're honest with ourselves and say to the patient, hey, I'll put an implant in today, but I know it's going to resorb over the next few years, be careful. Or I'm going to graft it today. I'm going to add bone. I'm going to over-engineer the case. And I think for all the surgeons in the room and people who do their own surgeries, I would tell you, I think that's going to end up being the trend in cases where you're going to have to be dealing with these types of environments. So bone is going to set the tone for now. The tissue, David can place his abutments and start shaping the tissue, and you can see how we can get a nice scallop, good thickness. And look, if you look at the papilla between the canine and lateral, you can see how that papilla height has been maintained with the natural dentition. We talked about this earlier. There's different dimensions, bone to tooth to implant dimensions between the underlying bone and the soft tissue fill. With implant to implant relationships, you're looking at about 3 millimeters, so you need more bone to support this tissue height. Here, you can be 4.5 millimeters away. Here, it's going to be 3 millimeters. And this is the publication that we did. This was 3 times it was published. The last time, 2007, in the IJPRD. And you can take a picture of this if you'd like with your cameras, or you can go to Dental XP and download the entire article. I use this. I have it laminated, and I hand it to every doctor in Atlanta that I work with. Because now they can't say to me, you make the decision. Because a lot of times I say, hey, you know, Dr. Salma, can you do this case? And I said, what do you want to do? You want to do 2 implants? You want to do a ponic? You make the decision. No, here's this laminate. Let's look at it. Here's the bone sounding measurements. Let's do it together. Are we going to do a pontic? We're going to do implants. We're going to do multiple implants. Or we're going to do an implant and ponic relationship. It has different proximity measurements. That means the height of the tissue in between the teeth from the bone level. And it also has what we would say proximity limitations, the mesiodistal measurements between the different restorations. So these are 6 possible fixed restorative environments that you can have. These are the proximity measurements, and these are the vertical soft tissue measurements. As an average, there is a range. We published this, as I said, in 98, 2002, and again in 2007. If you take a look now, we hand the case over, and David can restore the case, and this is in maintenance. This is a few years out, and you can actually see that around the implants, you don't see any color changes. You actually see more color changes around the natural restorations and the ceramic metal restorations than you do around the implants. So we really give you an idea of what we're seeing out there. And let me show you an interesting case. This is something that we'd see. Congenitally missing teeth, canines were moved into the lateral position, and they asked me to place some implants in the case. I didn't have a lot of space here, so I had to navigate. And we went ahead, we removed these resin bond retainers on this young man. He was in his 20s, and David said, "Can you put implants in?" I said, "I'll try to make sure I don't drink too much scotch that day." But I would also tell you that navigation or guided surgery is going to help you not have to be perfect. We went ahead, we placed 2 Prima implants in, and when the patient was ready to be restored, lo and behold, David comes in, he says to me, "I'm going to tap this off, are they ready?" And I said, "Yeah, the bone was good, the x-rays look great, look at these x-rays, they look really good. Go ahead and restore the case." Go ahead, David.
So I went ahead and started taking impressions. As you take impressions, you get a sense that because these were congenitally missing laterals, they never get the buccal formation of bone. So they're undercompensated on the buccal aspect. So you've got to tilt your implants quite aggressively. So we know we're going to do some sort of cementable at this stage implant over here. And as you look at it, I kind of get a sense. You see green coming through the tissue here? How much better would it be if pink was coming through the tissue there? I mean, green just doesn't meld in so effectively. Kind of like gray, isn't it? This is going through the impression-making process and, you know, the gentle emergence profiles that we develop. And as you see this, I've got temporaries in, but can you find the implants? Why? Yes, because of color. The color around the implant are not the same. This is even with the flash right up there. So normally this color that you're seeing here is even darker because of shadowing. It's a concavity plus being thin and the color bleeding through. So we've got to fix that up on both these 2 teeth. And really, what are the long-term implications now? Remember, Maurice said we've got thin tissue on thin bone. Both are going to degenerate. At least putting thicker tissue will tend to maintain the existing bone there. And of course, from my restorative perspective, it allows me to make prettier restorations. Remember, success in implants is all about aesthetics. That's how we define success today. So look at your tissue thickness. We told you at least 2 millimeters. At least. I mean, if you want to make it 3 millimeter rules, it may well be a lot better. So in this particular case, you can see the concavities, you can see the bleed through now of the gray, let alone the green coming through. In both the abutment and beyond that through the implant. So this is short term. What are the long term implications of all this? It can only get worse, can't it? It's not going to get better, is it? So we've got to intervene at this stage and try and do something. I'm going to do a tiny secondary perioplastic procedure. So we're going to do, you've heard of tunneling procedures. So we're going to do tiny little vertical tunnel. It'll go up there. I measure this distance. So you're picking up about 10 millimeters. I want a 10 millimeter long piece of tissue. We developed the pouch 10 millimeters up. You can see you use a mini blade that goes up, follows it, and you can see the exact shape of the pouch going up to this. I pick up the same amount of tissue from the palate, quite a thick piece, as thick as I can pick up from the palate.
And by the way, when you're grafting around implants, and this is a really good point, first of all, David's using a very small bendable microblade or ophthalmological blade, which I would suggest. But secondarily, I know I like to use acellular tissue when I can. This would not, for me, be an indication ever for acellular tissue. I think I would, with implants and thin tissue, I would always use autogenous tissue.
Absolutely. I mean, we haven't had as good results, despite what the literature says. So getting this piece of tissue up into that pouch is difficult. So I take a 4-0 needle, straighten it out a little bit, push it in there, through the pouch, out through the sulcus, grab it here, and then you go, pull it through, go through the tissue, reverse your needle, go back up and come out again there. And you've got two ends, your needle plus a piece of cotton. You pull on that, you'll slide this piece of sashimi straight up into there. Then you'd want to just put a tiny little suture in. You can see one suture to hold it in place. You take out the big suture. This is 11 days, 3 months, beginning to look better. You see we have a little bulge developing. And color not showing through, but we've cheated. We've cheated because we didn't like the green, we didn't like the gray. We actually put ceramic on this to compensate. Kind of trying to work our way around this. This is how we did it. We used the UCLA abutment. We waxed onto that with porcelain fused to metal. And then we added ceramic in this area. You can kind of understand how the Think Pink process came about. We've been trying to compensate for this for so long. And then we did 2, I believe, all ceramic crowns on it. Look at the grayness, or redness of this tissue rather. And then I put this in, and you see it lights it up the way we wanted to. Also look at the form we've developed of that tissue. This is where we started. Remember, this is what Maurice was showing you. Look what we've been able to do with really minimally invasive.
I would like to just make a point that this would be the time to intervene. If you see a tissue problem and you're either doing the restoration or you're the surgeon, doesn't matter who finds out, but if you pick it up before the final restoration's made, even if an impression taking, this is the opportunity, especially in a patient with a high lip line, aesthetically demanding area especially, this is the time to intervene and add tissue, as opposed to waiting for the final restoration to be placed and then wait for it to get worse over time, because then it becomes much more challenging to be able to work in that environment. When you can take the restoration off and you have access to the head of the implants, much easier for the surgeons out there to work inside that tunnel with those small bendable microblades. If you have a cemented restoration and it's permanently cemented, having to work around that crown, you may be able to use a vista approach or your tunnel approach, but it's just a little bit harder to work in that environment. And if there are any tissue changes that alters the crown, that would be an issue that then would require the crown to be remade. So better to intervene here.
So you're seeing what we're doing constantly in an effort to compensate for taking teeth out. It's not only replacing them with a support, but compensating for the change in the surrounding transitional zone. As we put it in, you can see what the single unit looks like. You can see how that buccal bulge helps deflect color because you're getting no shadowing, and of course, we cheated and we put in a material that would come through. So which ones are the implants? Remember, they're not these. These are the two canines. These are your implants. They look better than your natural teeth because we've really compensated for this pretty aggressively. This is 2 years in a pretty scalloped environment, and you can see how effectively it's held up and how, you know, we say the genesis of, and the implant happens to be called Genesis, why this did make perfect sense to us. We'd lived these problems. In fact, we'd lived it with Prima. This is kind of a version of Prima enhanced to compensate for the problems we'd had.
Actually, some people asked me a couple of different things today during the break. The thread design seems to be a little bit better for immediate placement because now these cutting threads go up a little bit higher. And now you have this anodized and pink area here at the neck that if we're having any issues with bone, long-term bone remodeling or resorption, if this is exposed, you won't have as much of the grayness that you saw in the previous cases. So we can take out a tooth, highly scalloped tooth, we place it again towards the palate or towards the palatal socket of the first bicuspid. So palatal always, even in this environment, but we have a little dehiscence in the area of the buccal root, where the buccal root socket was, and we're gonna add bone here to give myself that added 2 millimeters of bone in front of the body of the implant. And now David has thickness of tissue to work with. He can then take his impression and restore this case, and he never has to worry, even if we do get some resorption, that these anodized abutments will be able to maintain the color and the aesthetics.
And the single unit, as you can see over here, and how effectively it blends in really nicely. Again, the pink and white, that transition zone goes together. You have to work with them together. They are not separate entities. They are codependent.
So as we've taken you through sort of this whole concept of interface development, transition zone, I think we made some certain points to you, the fact that maybe we have to reconsider how you look at your cases long term. I think we need to go in a little bit different direction. And I'm going to share with you some concept that originated many, many years ago, but in fact for us changed everything in the way we practice dentistry over the last decade. If I want to maintain that transition zone, the best way to preserve a socket is not to have one. This patient came from Louisiana. Her father was an orthodontist. She was in her mid-30s, and she was devastated. Her father was devastated because she had this idiopathic root resorption that was basically overtaking her entire dentition. The resorption, cervical resorption, was going into the nerves. She was having pain. The teeth were brittle. Some snapped off. And the father actually thought it may have been his orthodontics that did it, but absolutely not the case. The problem that we have is today, if you look at a case like this, there's a tendency for us to, basically say, hey, all the teeth need to be removed and maybe all on 4, 5, or 6. This case was done over a decade ago, and I'd like to share with you how we managed it. First of all, we sent the patient to be tested. We sent her up to Albert Einstein endo program in near the University of Pennsylvania in Philadelphia, and we also sent her to the University of Pennsylvania, had the top endodontists evaluate her. They basically had no real solution. They said endodontics would not stop this process. It was very aggressive. And they said they don't really have even an idea of why this was occurring and that the teeth do need to be removed. What David and I decided to do is to maintain the space and stage the case, basically keep this patient in teeth. I actually did, knowing that these molars were going to be removed, I did sinus augmentations and I placed implants, but I maintained the 5 most stable teeth I could so that David can keep this patient dentate during the healing. So the first surgery was David did his temporary. He went to the lab to make sure it was fitting well. I went in, did the surgery, placed the implants, but then did not load them. We then came back several months later, and these teeth were starting to, again, cause pain. One had fractured, and we went through the process of taking the temporary off, and David took his impressions to try to now make an implant-supported temporary to support the one that she currently had. The question was what to do with these teeth that we had kept in the transitional phase during her healing. And obviously one was that let's extract them like we did before and do socket grafts. But as I told you earlier, even the best socket grafts, you're going to lose 20%. You've seen that from the literature. So what you're seeing here, rather than taking the entire teeth out, we ended up cutting the teeth down in the shape and rise and fall of the attachment 1 millimeter above the bone level. And when we did this, we were able, without socket grafting, to maintain these very, very beautiful and pristine ovaponic sites. This tooth, and this tooth were never extracted. They were cut down just barely above the bone level to maintain the supracrestal fibers. We round off the tooth edges and then cover that either with the flap or with soft tissue. In this case, it was fibrin and just a vertically advanced flap. We then followed this case several years. And by the way, for those of you that not noticing, these were not endodontically treated. They were vital teeth, vital roots. What we end up having is the maintenance of these roots, the preservation and maintenance of these peaks of bone that then support these papillas. And these teeth remain vital, retain their vitality, never had an endodontic issue. If you look back in the literature, say, those guys are crazy, I don't know what they're doing. I don't blame you, because when we first published this, David and I went out and lectured, we'd have people coming over, and you guys are crazy. And I said, I think so too. So how could you do that? And I said the same thing. But then I looked back in the literature, and I found this study. It was done at University of Maryland, in Baltimore, Department of Periodontics, histological evaluation of new attachment apparatus formation in humans by Bowers and his group, periodontists. He submerged vital roots in an attempt to enhance periodontal regeneration, guided tissue regeneration. And when he took his histological samples, what he found out was the vital roots he submerged retained their vitality. There were no periapical pathologies. And the cementum, the cut surface of the root, the cementum grew above the top of the prepared root surface. There was a greater percentage of positive regeneration of the attachment apparatus of all component tissues in the submerged defects, and no extensive root resorption, ankylosis, pulp death was observed on submerged roots. And I actually look back and say, you know what, David, we're not as crazy as I thought.
No.
I actually think this may make sense.
And kind of interesting, because think about it. Think about the amount of work to take those teeth out. Those teeth did not have periodontal ligaments, so you had to cut them out. Look at the defect you would have really iatrogenically caused. Look at the time, look at the cost in time and bone grafting.
And lack of predictability.
And lack of predictability. We know whatever we do, it's going to get worse because we're taking out the blood supply to that labial plate.
If you ever want to have a lot of fun, try to take out teeth with cervical root resorption like that. They're blessed. And once you grab them, they shatter, and they're usually subcrestal. And then they have some spot ankylosis, makes it even more fun. Or try to take out ankylosed teeth. That was a lot of fun too. So if you look at this, why take them out? This patient comes back in for hygiene. She lives in Milwaukee. Periodontist sees her there, a friend of ours who told us we were crazy when we sent her back, and he now maintains her, and now he's doing these. And he sees her and sends her back once a year, and her bridge got loose. So she came in, David tapped out the bridge. I said, David, this is a perfect opportunity for us not to only take photographs. Here's one of the sites. Look at the papilla, how it's maintained. Look at the ponic site, keratinized gingiva, completely healthy. No collapse of the tissue, convexity in the area of the canine. When she smiles, there's her submerged root. Nothing has been lost, ladies and gentlemen. Not so crazy after all. We published this in December 2007. I was only 14 years old.
11
And the
years, man.
conclusion of the procedure of this paper was this procedure should be considered as an alternative to the standard socket preservation techniques to better preserve fiber apparatus, interproximal height of bone, and ridge dimensions. There's no doubt that there isn't a better socket graft than not having a socket at all. We take a look at this case, and here's that day, 3 years later. This is the central, this is the left side, the pontics. She had a little chip David had to repair in the lab, and we put the case back in. This is now several years later. No hybrid prosthesis, no all-on 4, 5, or 6, just standard implant dentistry, fixed restorations, maintaining as much of the ridge and the tissue as we can. But I wanted to know more. 12-year follow-up, she comes in, again, it's a cemented bridge, got loose, we took it out, cleaned it off. We took these radiographs. Take a look at these radiographs. No periapical pathology. What do you see right there over the cut surfaces of the roots? If you colorize them, I think what we're seeing is that cementum or some type of calcified material is grown over the cut root surfaces. This is not Photoshop. This is not trick photography, because David and I are too old to know how to do that stuff.
Especially David.
Especially David. But bone or cementum is growing over those cut root surfaces. So, from there, an idea came about, published in 2010 by Marcus Hertzler and Otto Zur, which talked about socket shielding. They said, if this worked so well, and Marcus is a friend of ours, he said, if that works so well, how about if we just take out the tooth but leave just the shield, 10% of the labial portion of the tooth, 1 millimeter, to fool the body into thinking we didn't take the tooth out. Place the implant behind the shield. Then you wouldn't have the resorption of the labial bone and the labial tissue. And we started looking at this. We call it partial extraction therapy, whether you take the root and leave it in place to support a pontic, or whether you take and leave behind just a shield and place bone behind it and do it in a staged approach, or whether you leave a little portion of the tooth, 1 millimeter of that labial shield, remove all of the root canal eminence and space, remnants, and then place the implant behind the shield, called the socket shield. All of that preserves what? What we started this morning in our presentation, the transition zone. That would impact those 4 to 5 millimeters we talked about this morning in those cases that David had to handle prosthetically or that I had to handle surgically to recreate what we had lost. If we can preserve it and maintain it, then it wouldn't need it. Let's look at Catherine. She comes up from North Florida. She has a tooth. She's really upset. She's maintained all her teeth throughout her life. She's a retiree. She drove up to Atlanta, says she was told her left central incisor needs to be extracted. It's losing bone. She's having sensitivity. And what are the options and solutions today? I tap on the tooth, and what do I find out? I hear that hollow thud, starts to think to myself, that part of that tooth is ankylosed, more than likely partially in this area. And the standard extraction is going to be traumatic for this patient. Even as atraumatic as I can try to be, I'm going to traumatize some of that bone and tissue. She's very, very focused on the aesthetics. She told David, I want this to look as good as it can. I have all my teeth. I never lost a tooth before. I told David, we have an option. One option is we can do surgical veneer grafting. This is something where we talk about putting bone in the gap between the implant and the socket wall, and then tissue in the tunnel outside it to compensate for any of the damage we cause. This is something that we published a few years back. Or we can do something that has been published in the literature, socket shield. Another team in Greece with David published this years ago, called the root membrane technique in 2014. Basically where you take out all of the root, all of the canal remnants, and just leave behind this shield. But why? Because this bone that was so thin, so cortical, so poorly vascularized, if this shield is there, the periodontal ligament remains, and therefore you won't have the remodeling episode that you have with a conventional extraction. They looked at 46 cases over 5 years. They found 100% success. Obviously, these are experienced clinicians, but this was early literature. I'm going to share with you what we have so far. So I went ahead, I cut the tooth down. We need new armamentarium. They didn't teach us how to purposely leave behind a portion of the root. I didn't learn that in dental school. Anybody learn that in dental school? No.
No.
I usually leave behind portions of a root by accident. And then everybody now, the problem we have with socket shields, people say, yeah, I did socket shield there. I didn't do that on purpose. It just kind of happened that way. If you're going to try to do this, you can't do it with your standard instrumentation that you have in your offices. You need longer shank burrs. You need different types of burrs. You need a couple of carbides, you need some tapered diamonds, you need round burrs, you need end cutters, because you're now trying to keep behind a tooth and not mobilize it. So we created this kit. Brasseler sells it. We really allow them to do whatever they want with it here in the United States, but there are other kits elsewhere. IDS has a kit. Comet has a kit that they sell in Europe and South America. A lot of people are making this kit. This is not just something that we're doing in Atlanta. People are doing it now all around the world. So you have different depth markings, 8, 10, 13, 15 millimeters, so you know how deep to go. You cut the tooth, separate it into a buccal and lingual component. You then subluxate the palatal portion. You take it out. By the way, I did this, and I haven't prepped a tooth in 26 years. I think that's a pretty good cut. What do you think? I think
You were having a good day.
It was very good burrs. Very good burrs. Now the big thing is we have an option. One is to stage the case, meaning that you can hold on to this shield and pack bone behind it, come back later. We published on this in 2016, IJPRD, and we called this the Pontic shield. Basically, you don't have to put an implant behind it. We can wait and just pack bone in there and preserve as much of the ridge as possible. Or we can place an implant right away. We keep the implant away from the shield. The shield thickness is 1 millimeter. We don't like to do it much less. We reduce the shield. Unlike with submerged roots, we like to move the shield right down to bone level. We don't leave it above the bone. And this area right here has to be beveled because we need space for the prosthetic abutments and prosthetic contours. So what you're seeing here is I'm going to shorten this down to the bone. Here's the bone level. I'm going to use a shield, an actual protector, if you will. And I'm going to prep this down with an end cutter. And this is going to be 3 millimeters routinely, the biological width. So the shield must be prepared 2 to 3 millimeters below the gingival margin. No sharp edges should be left behind. And then in this space, we're going to place the implant. And then between the shield and the implant, if it's a large enough space, we place a mixture of growth factor, PRGF or PRF, mixed with cortical cancellous processed cadaver bone. We then cover it with fibrin, and we close this up. I can then come back later and allow David to do all the things that he used to do with conventional implant restorations, is start to create the emergence profile and tissue molding.
And you go through the process exactly as you've seen us do. And we replicated her tooth. You can see it's just behind the lateral. It matches the adjacent tooth. And she has the soft tissue interface looking exactly the same, if not slightly better than she was originally, which was obviously part of the goal. The nice thing is, it's really, we're utilizing biology to do this, not the unique skills of Maurice.
What? What are you saying?
That's really kind of nice.
I thought I had unique skills.
You do.
You've been telling me all these years.
He does have unique skills. I mean, he is really a master surgeon and does things intuitively. But it's really, you need a very high skill set, as you've seen, to handle the polo player and people like that.
I want to preface something right now by telling you that this is not something that I would come to this course, see it on the stage, and then go back and immediately start implementing it routinely in your practices. I think you need to go take a hands-on course, learn more about it, do your own research, be inquisitive, question everything we're showing you. Not that we're lying. I'm going to show you follow-ups on this because I question it myself. I review every single case and painstakingly been reviewing my cases, and I'll show you some of the human histology that we've just recently published on as well. So we looked at this case. This is 3 years back. She comes in. She didn't lose much of anything. And if I didn't tell you that this was an implant crown, I don't think you'd be able to tell. It looks exactly like the adjacent site. So I took a cone beam CT. Remember that cone beam CT David showed you earlier where this was gone? Well, look at this one. Here's the tooth. Here's the resorption. Here's the implant. And here's the implant 3 years with the cone beam CT. Here's the shield. Here's the implant. Here's the space. And here's the shield on an axial section. If we take a look at this on the facial aspect of a 3D, you'll see bone is there as well. We haven't lost any bone. The bone is completely there. No remodeling, 3 years. No additional significant bone grafting was done. No tissue grafting to compensate. Just socket, a little bit of socket grafting.
And if you think back, everyone always asks, what about the area that was actively resorbing? And what happens in those areas? Remember, whatever is resorbed of the bone and the root gets replaced with bone. The best thing that can happen is you allow biology to maintain it naturally.
So we take a look at this. We published this in 2016. Part 1 was on maintaining alveolar ridge contours using this technique. We have a table where we talked about when we would use each type of technique, and we also talked about the relative literature that has been proposed since 2010 all the way till 2016. Now, we did one better for you. Recently, with Chuck Schwimmer, Howie Gluckman, Jonathan Tutois, Greg Petty, and myself, we had a patient that this was done unintentionally. An implant was inserted with a fragment of root still remaining in the area that the dentists were not aware of. Patient ended up having an infection, and they suggested the removal of the implant. When the implant was removed, they ended up taking this section and taking this implant and submitting it for histological evaluation. This is the root, this is the implant. And when they took these magnified images, what you're seeing between the root, this is the cementum of the root, this is the bone that grew between the root fragment and the implant. The black that you're seeing here is the titanium of the implant surface. On polarized sections, you can clearly see living bone that was placed in between the root and the mistakenly, without knowing, implant placed in contact with the retained root fragment. Here's another case, internal root resorption. Look how much resorption in this case. Ankylosed tooth, if I remove it, tremendous amount of damage there as well. I do the same thing I showed you earlier. Section it, take it out, prepare the osteotomy, place my shield, protect it, cut the tooth down to bone level, make sure there's no sharp edges. This is all now just 3 millimeters of unsupported tissue. And now we place the fibrin. There was no bone grafting and no soft tissue grafting done in this case because there wasn't much of a gap. No bone grafting, only a plug of PRGF, just growth factor from the blood. This is what it looked like when David ended up seeing the patient after 3 months. This is after 3 years. Look at the shield. You can clearly see it alongside the implant. Look at it from this vantage point. Have we lost anything on the labial here? This is now a few years later. Nikon, a little different camera, but you can look at the color of the tissue. Look how it's stippled. It looks like there's a root there because there is a root there. And if we look at it on cone beam CT, here again, you see the root fragment, you see the implant, you see the space, and you see the volume of bone. This is the pre-op, and you can see the post after 3 years. We're starting to collect data on this, and it's becoming exciting, and I wanted to be able to present it to you. I want to hold off the questions until after our presentation. I know there'll be many, but I'm going to try to kind of round things up, and we have a few cases left, and I want to get to full arch dentistry. First of all, David and I obviously have the advantage in many instances. We have an advantage that we work together in the same facility. I'm able to tap on him, he can tap on me, and we have an in-house laboratory that can help us as well. There's a huge advantage to that. With full arch cases in particular, I think the advantage is also that we can do things either immediately or staged. And I'll take you through a case that we did over a decade ago. Patient that was losing her dentition, came in. She was actually worked at the salon that David and I go to, as well as our wives. I told him, the worst thing you want to do is ever make your hairdresser or person that takes care of your wives upset with you. You never know what kind of haircut you're going to get. This patient was losing her teeth. She had decay. She had unreparable damage to her teeth. She had some festering periodontal issues. And the question, obviously, today in any group of dentists that you speak to is, take out the teeth, pick 4, 5, or 6 implants, and do an immediate conversion. There's nothing wrong with that. We do that too. But in certain instances, David and I still prefer the old school way of staging the cases. I think we maintain more ridge volume. I think we maintain better control of the aesthetics and the soft tissue. And we don't have to rely as much on artificial gingiva and hybrid restorations. Just a different, we're going to share with you, we do both. Just sometimes when we have patient with an aesthetic lip line, that transition zone is intact. I want you to remember again, if the transition zone is intact, try to come up with a different environment to solve it, because why would you take a patient who has an intact transition zone and transition that patient into a hybrid artificial gingival interface? Patients come in and they have severe vertical bone loss, they've been wearing dentures or partials, and they've lost that bone, then obviously the point is moot. That's an indication for a hybrid restoration. David and I, again, like we did earlier, prefer stage therapy. David says, according to this cone beam CT, Maurice, I think we can hold on to these teeth here while we transition the patient. I'll remove the decay, put some temporary IRM fillings in those areas, while you go ahead and place the implants and do your sinus augmentations in the posterior area. So David keeps some of these teeth. There's the decays that he just filled temporarily. And I can go in there. This is, again, a case we did our early experiences with the Keystone, the Prima tapered implant. So the implants are placed, teeth are extracted, and we basically utilize, for me, rather than just fully guided, this was the case we did in 2006. So we actually utilized his temporary restoration, and I kept the pallet on it, and that gave me sort of a guide to where my screw access holes would be. Today, obviously, I'm about to show you, we can do way better than that by having fully guided implant surgery. There's still a lot of surgeons that prefer to do it freehand. Nothing wrong with that, as long as you have a CBCT to plan it. But at least, at the very least, I would tell the surgeons working is at least have some type of restorative guide to place the implants in the right position for your restorative colleagues. Bone harvesting with these drills, I used to do on slow drilling, and you can see that it used to pull up quite a bit of the bone in the flutes. I still use that concept. We then can go ahead, take the implants, place them immediately in the areas posteriorly around those teeth, and the implants are inserted. This is a rather large first bicuspid extraction. You can see the septum. Never going to place an implant here, and I don't like to place an implant in the septal bone. I told you earlier, I'm always going to try to aim palatally. So in the back of the mouth, posterior areas, you'll typically see me engage the palatal sockets of these bicuspids. I want the drills to come out directly for David to have a screw retained option. The implants, typically for me, when I place them, I want to place them down at least to the crest of the ridge or slightly subcrestal, depending upon the restoration and the quality of the bone. So now the implants are placed. I'm going to graft those areas. You can see how they're going to be exactly 3 millimeters from where David envisions the final restorations to be. And I'm going to pack that autogenous bone that I harvested and pack it into the extraction site. And I close this over with some fibrin, and you can see the implants now at or slightly subcrestally placed. We talked about 2 millimeters of bone in front of the implants. Just simply, if you place an implant palatally, you're giving yourself a chance to maintain that because that bone is not extra alveolar. That bone has more of a chance of staying than bone that you pack out beyond the alveolus. So bone that's out here is going to have more resorption possibilities than bone that's within the alveolus. We went ahead and placed some sutures, and the patient leaves with the same restoration. Now, when these posterior implants are ready to be loaded, David now, in 2006, remember, we hadn't come out with partial extraction therapy yet. David says, okay, you gotta get rid of these teeth because they're fractured, decayed, and I don't want you to have to go down to osseous and do crown lengthening, ruin the contour. And this patient was also dry mouth. She had an issue with decay, so this patient wouldn't have been a good candidate to keep these teeth anyway. If this was today, I would tell you I'd be doing partial extraction therapy, no doubt about it. But this was 2006. These roots came out. They were a little bit discolored. They were treated in Eastern Europe with endodontics. I have no idea what they filled these teeth with, but I couldn't have been good for her. I just don't believe it. I have no idea what the material was, but couldn't have been good. But here are your sockets. So we're going to go ahead, and David mentioned this earlier. This is an article someone asked me during the break about when I decide to do an immediate, when I don't. This was the closest article that we ever wrote that delineates when we would and when we wouldn't place an implant immediately. It gives you the indications, it gives you the success rates, and it's on Dental XP. It's timing, positioning, sequential staging, and aesthetic implant therapy. It's, again, one of the articles that I truly still live by, published in 2007. Immediate implant placement, fresh extraction site. Some of you are asking me about the Prima system. Did I do it immediately? Absolutely. I think if you utilize the drills correctly, under-prepare the apical aspects, I got good initial stability, placed the implants, grafted this as a dual zone socket preservation case, and then we utilized angled, contoured abutments. This is something that was available, still available with the system, that allowed us to take care of the angulations anteriorly that David was able then to deal with. And you can see with the overlay of the temporary that these abutments allowed David to manage the angulation challenges anteriorly. So all of this was at least basically managed through the original wax up and original provisional. Abutments in place. You can see he now has them coming out directly underneath the future teeth. They're going to be in his restoration, and they could be immediately loaded. So the first sets of implants were staged. The second sets of implants were immediately attached and immediately loaded. Immediately placed, immediately loaded, maintaining as much of these contours as we can. Now, David can go ahead, remove this, and David, you can maybe touch upon the prosthetics here.
So the prosthetics is conventional prosthetics. At that point, you join them, albeit that this is up for grabs on, is this a good way to do it? But if you're going to join it with Duralay, you have to let that Duralay cure. So we join it on a model first, let it cure for about a week, then we make tiny little slices and put it back in the mouth, and then just add Duralay in those little cuts that separated it. Otherwise, you will get distortion, and it's actually better just to take impressions without Duralay.
And today we're using a lot of Easy Bar, right?
So we have a system now called Easy Bar, which effectively makes this for you in tiny little metal components, and you've only got a tad of not Duralay. You can use curable composite and hold it. So you've got metal, which is really stable, as opposed to long-term cured Duralay, and then the same amount or little increment that really limits your distortion, if any. And the nice thing with it is it doesn't flex at all, so I can take it out, and see that it goes back in totally passively. Obviously, checking to see that you're down and developing the potential prosthesis from this. You can see how we are going to use cementable on here, and that we're bringing this interface really high up. You want the interface now of the crown and the abutment no more than 1/4 of a millimeter under the tissue. Because if you do any more than that, you will get cement down that you won't get out. And I know, because I found my cement under there on a routine basis. Even packing cord, and I've had to do surgery and go and dig it out. I've found that 8 years later when it suddenly flared up. Cement is a major issue. So watch how this is done. You really need good tissue impressions at the time when the tissue is healed.
And that may be one of the advantages today using multi-unit abutment systems, because you have a screw-retained prosthesis. You don't have to deal with cement. I think any surgeon in the room would tell you that our worst nightmare is cement being pushed up underneath the gingiva.
Sorry.
There you go.
And this is bisque bake. We're doing traditional porcelain fused to metal, and we know that works. We've used it for a long, long time. Sorry, did I push? Looking at it, you see it in its glazed phase. And look at the quality of the tissue now. Remember how red and inflamed and overgrown it was getting coming out of the sulcus, actually. And long term.
Several years.
You now remember, this case started in 2006. We're talking about 12 years ago. Why is it going? But
on the lower incisors, we splinted her. She didn't want to proceed, and this is 2006. We resin bonded the lowers and just did periodontal procedures. And then she wanted a little bit better cosmetic alteration, so we just went ahead and did some bonding of these lower incisors. And they're still in the mouth now. This has been 11 years, 12 years.
And this is what she looks like, you know, currently. And really very, very effective. She really doesn't show that tissue, but the tissue is great. And really an older but particularly attractive lady who just has the nicest disposition. Just wonderful.
So this is 12 years post-op on a case, and really for us, we have some radiographs that we shared over a few years afterwards. Very interesting to see how well the bone has been able to be preserved. This was radiographs taken at 8 years, and you can see that very, very good crestal bone preservation. You have some remodeling at the crest, maybe down to a first thread, but tissue quality has been upheld, and because of the splinting of the anteriors and the posteriors, they were broken up in this case, but we still have very, very good crestal bone response. And again, taking a look at this over time. Again, displaying our dirty laundry. Sinus graft here. She didn't want sinus graft here, so I decided to see whether or not my implant skills would be good freehand, and you can see why guided surgery may in fact have helped me. I got lucky here. Look, that tip of that implant, I did that. I placed it into the sinus inadvertently, and luckily for me, she has no pathology and hasn't had an issue. One side sinus augmentation, people ask, is it necessary? Absolutely, and it does maintain itself over a decade. Luckily for me, this is not an issue. For her, it's not an issue, but this should have been something that I could have avoided with maybe a guided procedure. So we kind of took you around I'd say the way we look at cases, the way that we interact in our practice, what's important to us, what we envision down the road, where we're seeing issues. We try to be as honest as we can with you today. We showed you our dirty laundry. We showed you some cases we did okay, some cases we did well, and some cases that we had some little issues we should have been able to do better. Where are we today, and what are all the potential options we have with modern technology? With this last case, I'd like to take you through what I think is possible. I share with you some of the new dentists on our team. We have 2 new prosthodontists, Marco Todris, as well as Marcelo Silva, Paula Silva, his wife, Nadia Esferranda. Really some wonderful young dentists. They're all in their 30s. It's great to see. And they bring some great new technology to our team and all the digital components, 3D printing, and really all the things that we can do with guides that can be made in the office. So it's exciting because, you know, obviously it's for them it's second nature, and for David and I maybe a little bit more challenging. So they are kind of what I call Team Atlanta 2.0. So this is a case that we did with this new team, and I'll share with you how we handled it. Patient came in, she was a school teacher. She was obviously severe periodontal disease that she'd been susceptible to for many years. Her teeth were extremely mobile to the point where she really couldn't masticate comfortably at all. She was desperate. She had gone to a few different dental offices who told her she'd have to have all the teeth removed and dentures placed until they healed, and then she would end up with overdentures. She was really distraught over that, wanted to know if there was other options that we can provide for her. If you take a look at her now, one of the problems you have with looking at cases like this is you have the transition zone right in front of you. It's not a patient who has all of this happening underneath her lip. So anything that we do, you're going to see. It's going to be an issue with tooth proportion. It's going to be an issue with any interface that we leave exposed, so we have to plan that as well. She also has migrated. The teeth have migrated labially. She's lip incompetent. The teeth are labially inclined. Where do you actually start to place your implants? Do you place it in the position of her current dentition, or do you try to sort of clairvoyantly decide where the teeth are going to be in the future? That's a big question, because if you place implants in this patient not knowing where the teeth are, that's going to be an issue. So what we went ahead and did is we took a cone beam CT, we evaluated the patient. You can see there's a reason for all the problems she has. She's just basically given up on her mouth, and it's a shame. There's a lot of patients like that out there. Multiple diastemas, migration, drifting, large spaces, teeth that are 2+, 3+ mobility, severe dental inflammation, bleeding on probing, severe bimaxillary protrusion, lip incompetence because the teeth have migrated labially. So one of the first things that we like to do is get an idea. Before you get on a cruise ship, you want to know where the ports of call are. You wouldn't get on a cruise ship if you didn't know where you were going. So the first thing that we want to know is, let's plan the smile. David and I in our office, since Christian Coachman was with us for several years, and Guy Cabral, we do it digitally. We actually take photographs, we get the center line, we get the lip line, we get all this information, and then we start to plan the case. And it used to be two-dimensional, meaning that you can get an idea of where the teeth need to be, but it was relied on a two-dimensional template. And today we can do this in 3 dimensions. We can actually get a ruler that tells us, basically we match it to the photograph, and that gives us an idea of where the teeth need to be. And you can see all the problems we have because of the multiple diastemas. But we have this technology now, and we can use it and match the optical scan that we take intraorally to the DICOM files, and we can then stitch it on and get this idea of where the teeth need to be in 3 dimensions. So 2D moved to 3D in terms of digital smile design. This was published on by Christian and his team, and really gave us an idea to allow us to not only see the proportions of the teeth in 2 dimensions, but also 3-dimensional solutions, utilizing DICOM files from CBCT imaging, optical scanning, STL files, and then CAD/CAM files that leads to a 3D printed conversion and guide.
And this is really an amazing process compared to what we looked at 2-dimensionally. Adding 3 dimensions takes it beyond the individual skill of a Christian or a Guy to translate the information. And you've got 3D because by virtue of the CAT scan, you've got it there. you can superimpose and register your triage scan, which is just a surface scan. And because you now have cusp points that are fixed, you can take this, which is surface scan, overlay it on the 3D, and they meld together exactly.
So if you take a look at what we're seeing here already, Marco and Henry and David, we're looking at changing the position of the gingiva from what she currently has, giving her less gummy display. So already we're about 3 millimeters up. So we have to plan for that in implant placement. I'm not going to place the implants where her incisal edges are because we need to basically treat her orthodontic problem digitally. So we're going to do digital orthodontics. We're going to actually retract her teeth digitally where we envision them to be in the final restoration. Now, how could we possibly do this without all this technology? So we do a facial scan. We do a 2D and 3D assessment of her digital smile. We then superimpose it and retract the teeth digitally and stitch it back onto the DICOM files. So what you're seeing now is how far these incisors have migrated in the anterior. We're able actually to move that and do this in this fashion. So what we're seeing is an opportunity today to actually get full facial digital scanning in real time. We can take those scans, and this is the facial scan we have on this patient, and we can see what we can do by actually moving her teeth in lingually. What would it do to her face? What will it do to her lip support? What will it do to facial contours? So this is really unbelievable. Take a look at this. This is how she comes in. This is her teeth in position. This is the blue. And the green is where we envision them being placed. Look at the distance that we're going to retract her teeth. 7 millimeters. Where her incisal edge is now and where her incisal edge is going to be. 7 millimeters of difference in terms of where the implants need to be placed to be correct for her face, for her smile. So this is how she walks in. This is how we digitally did her orthodontics. This is where her gingival position is. All of that done sagittally and planned beforehand.
I must tell you, Mo, I mean, I look at this at the podium. I've seen it from the podium and from the floor. I'm still excited by it. I mean, this is really incredibly exciting, evolving technology and makes our lives completely different.
As a surgeon, I can tell you, I mean, I'm an orthodontist by training, so it was amazing to me when I sat with Marco and we were looking at the digital wax-up and the orthodontic implication of that wax-up to do digital orthodontics. It's pretty amazing. Look where the implants are going to go. We already know what multi-unit abutments we're going to need because we see the angulation, but look at where this implant's going to go in relation to where the tooth's going to be. It's completely in a different position. And we can see that clearly here on these images. So here we're going to end up with a all-on-6 upper and an all-on-6 lower with angled distal implants. But we're going to be able to do it at her perceived tooth position as if she had orthodontics and had orthodontic correction. We're also going to be able to manage the transition zone between her lips, gingiva, and teeth by maintaining a scalloped architecture. We're not going to just arbitrarily reduce bone. Yes, do I have cases that I do that? Of course, overdenture cases, patients with hybrids where we need space, but not all of our cases. This is a really new concept. We just submitted the publication to IJPRD called scallop-guided surgery. Fully guided 3D surgery. Now I can place that. I keep a couple of teeth that are the most stable to give me a very good, accurate seating of my guide. And when I'm placing my implants, I'm now placing them where we envisioned the teeth to be in the end of treatment, not where they were originally. So I place the implants incisionlessly, but I know that I have to do more bone grafting. So I extract the teeth I retained for the guide and then raise my flap. So I actually place the implants incisionally and then open up the flap, and now I'm going to do my scallop guide, minimal bone reduction, and grafting of the other sockets. So implants placed, we now can place the intraoperatively. We're going to do immediate loading of the upper and lower arches. We place our multi-unit abutments and our temporary cylinders. And this is where it gets interesting. Here's the grafted sites. Look at what we did here. I actually didn't just arbitrarily section all the bone into the vestibule. I actually created, in the transition zone, a rise and fall, a scallop of the bone to support a more standard traditional restorative interface. And if you take a look at what we talked about earlier, this is the temporary restoration. When it's inserted, you're now 3 to 4 millimeters from where the bone is, and we've scalloped it to better appreciate the scallops and the emergence profile of the restoration. So not blindly done, we're calling this a 3D guided scallop bone reduction guides, which now allow you to follow the scallop, and the restoration is pinned, indexed into these guides. So this is an incredible technology because now you have a restoration that fits onto the guide. It's stackable, which is really incredible. And now I can go ahead, place my grafts, place my fibrin, and I can suture and allow the restoration to be relined in the lab while we move to the lower arch. The lower arch is the same thing. Extract some teeth, keep a couple of teeth to seat the guide, place the implants immediately, raise the flaps, do the bone grafts, place the fibrin around it, and then suture with PTFE sutures in the same process that we did in the upper arch. This is very, very advanced technology here. Inside the screw access holes, David has patented the David Garber toothpicks. If you want them, they're $0.25 of a penny each, but he sells them by bulk load, 5,000 a pop. That gives you about $5. We're going to go ahead, send this to the lab. While this patient's being sutured, we then have the temporary, and it's seated. This was the pre-op. This is how we planned the case on the panoramic films. And you can see how the implants and the multi-unit abutments and temporary cylinders are inserted. This is the PMMA. Look at how these teeth were retracted. Look at how we've managed to maintain some nice contours of the tissue at 2 months. You can see very nice, healthy, soft tissue, thickness of the gingiva, healthy tissue. She's been doing a great job, recommitted to cleaning of these surfaces. And then the PA films at 2 months. Now we can take this information, we can scan the temporaries, and we can then scan intraorally the soft tissue frame, and we can send this to the lab. We did this with Pinkas Adar, and he can transition this patient into full monolithic zirconium in the upper and the lower arches. So here we're going from the PMMA to the monolithic zirconia. Pinkas is able to do this in a very elaborate way where he stains in the green stage, and he's able to get very, very beautiful and realistic translucency. This is the PMMA after 4 or 5 months. You can see how much it's stained already. This is the final zirconia that Pinkas was able to make that's pretty much duplicated from what the patient presented with. So temporary after 5 months, new PMMAs. Preoperative.
Occlusion is quite remarkable because you've scanned the temporary that she's been wearing and grinding and make perfect, better than I could ever adjust. So it's ideal. It should go straight in.
You see the pre-op on the lateral ceph image, how much bimax she was. Look how much we were able to retract her orthodontically, and look at her now with the face when she's smiling, complete lip confidence now. She's able to close her lips naturally when speaking and when chewing. Look at the tissues before the final insertion. Look at the scallop in that interface that was maintained, and in the lower arch as well. This is the transition zone. We started today talking about the transition zone. We talked about how important it was, the lips, the gingiva, and then the white portion of the aesthetics. Look at how this was managed without having to go up underneath the lip and just arbitrarily sectioning an additional 10 or 15 millimeters of bone and giving this patient who's in her 30s a hybrid restoration. I believe this is more cleansable, it's more realistic for her, and very much in line with what she wanted and what she envisioned. So the transition zone is something I want you to focus on, whether it's full arch cases, whether it's damaged sites, or whether it's ideal type 1 sites. we want to do as good a job as we can. Even the slight asymmetry at the midline on the central incisor, we just take away that tissue to try to match it when we seated the case just with an electrosurge. But what's really great for us is when we see the patients over time and how they actually disseminate to us their feelings on the transition from hopeless teeth to a realistic view of what they wanted in the final restoration. The pre-op, no hybrid prosthetics, no major bone reduction, just slight scalloping of the bone. This is what she looked like preoperatively. This is the post-operative view. And then more realistically for me is to see this young lady when she gets up. First time seeing her teeth.
You like it?
Yes.
Nice. You want to go on back on there, right? Go? Yes, we will. We will do it. Not today, though.
No.
He asked her if she wanted the gold tooth put back on. She said no.
Oh, yeah, now.
And then she said, this is one of our doctors, Wendy, prosthodontist, who's now at University of North Carolina. And she said, I want her teeth. And that's, to me, what a lot of what we showed you is all about. And the conclusion for us today is that really it all comes together for us in this transition zone. 4 to 5 millimeters is makes or breaks the aesthetics of implant-supported restorations. Where team success really comes together is in that transition zone, because you need the surgeons, you need your restorative colleagues, you need the laboratory, and you need great implant companies with great implant products and components and support. And for us, this really is all about being able to give back, not only to you, but to the community. For us, as a summary of components that we feel of a successful implant system, many of them are matched right here: tapered and straight implant options, macro and micro geometries of the implant, internal rigid connections, several restorative options, platform switching built into the design, and the versatility to be utilized in all areas of the mouth. For David and I, Ronald and Henry, we were Team Atlanta 1.0. As I showed you that last case, that's really the new generation that we're trying to really bring into the practice, really hopefully take our place so we can go out golfing and hang on the beach, right? So next time you see maybe somebody invited to this meeting, it'll be a bunch of younger, talented, and technologically savvy dentists from our office. I also want to let you know that part of Team Atlanta is sitting in the front row. For anybody who doesn't know, my brother Eddie is the CEO and manager of Dental XP. It's really his baby and his idea, and everything that has happened on Dental XP over this last 9-10 years has been with all his arduous hard work in implementing all of the fellowship programs, the live courses, the hands-on, and the summit that's this August. I hope many of you will come see him, ask him about some of the courses we have. Come join us in Atlanta or anywhere around the world, but hopefully in New York in August. David and I thank you very, very much for your kind attention today.